welcome everyone to today's AROC webinar on common clinical questions. Just wanted to note before we get started that I have got you all on mute, but we will be pausing at the end of each topic to allow for people if they have any questions or issues or examples they want to go over. So we will unmute you during that time, and you can also type questions as well. So today's webinar is part of a series of webinars AROC has started this year. We held 2 in January on data entry and data upload, and we have got 2 coming up in March to tie in with the release of the your benchmarking reports. They will be on understanding and interpreting your benchmarking reports and the dashboard report. All that information can be found on our AROC website. We've got a page dedicated to the webinar. It's got the webinar schedule, and the recordings of those webinars can be found there too. Okay, so today we're going to cover a few different topics. We're going to look at first how to record the end-FIM score if a patient unexpectedly leaves the rehab program. Then we'll be looking at the coding of discharge destinations, comorbidities and complications, and then to finish off we'll be looking at suspensions of the rehab treatment. For each of those topics we'll go over a definition, look at the relevant data items and code set, a couple of general rules and then some examples. And as I said before, we'll be pausing at the end of each topic just to allow if anyone has any questions or issues they want to go over. So the first topic, how to score the end-FIM if a patient unexpectedly leaves the rehab episode. This is probably one of the most common questions we get. So that's how to score the end-FIM if a patient dies unexpectedly or if the patient is transferred back to acute care and is not returning to the episode of rehab. So as we all know, functional change is a key outcome measure of the rehab episode, and it's important, therefore, to collect the discharge end-FIM score before the patient is discharged from the program. However, if the patient dies or if they're transferred back to acute, this isn't possible. So here we're looking at how do we score in these 2 situations. So there are 2 ways to score the end-FIM if a patient dies or if they're transferred back to acute care. The first way is to score the FIM to reflect the function of the patient prior to their death or their transfer to acute care. The second is to to enter 1 for all the end-FIM items, coming to a total of 18. The first option provides you and your team with more information about what the patient was able to achieve during their rehabilitation program, and we would encourage this option. The second option won't provide you that level of feedback on the function they were able to achieve. So where a mode of episode end for a patient is if they've died or if they've transferred back to acute care, AROC considers this episode incomplete, and these episodes won't be included in outcomes analysis. They are analysed separately. In talking about what is an incomplete episode, just quickly, a complete episode. So for an episode to be considered complete, it has to have a mode of episode end of return to community. So that's discharge to an interim destination or a final destination. And the total FIM score has to be greater than 18. There are a couple of circumstances where the FIM score, say in brain injury or spinal cord injury, where they might get a total end FIM of 18, but that's special circumstances. If your patient returns to rehab following a transfer to acute care, it's a different circumstance. So we will be looking at situations like that when we cover suspensions of treatment towards the end of the webinar. So we'll stop here if anyone has any questions or issues if they want to raise. Did anyone have any questions or issues they wanted to raise? So the type of accommodation, this is the type of accommodation the patient is going to following their rehabilitation program. So here we're looking at, was the patient able to return to their usual accommodation, or did they need more support or assistance going home? So for example, did the patient come into rehab from their home and were perhaps discharged to a nursing home as they required more assistance or support? Or was the patient able to return back to their own home, perhaps with modifications or some services in place? These are the relevant data items for discharge destination. So we're looking at mode of episode end, interim destination, and final destination. And we've got the code sets listed there underneath. So for mode of episode end, we are looking at the two broad categories someone can go to following their rehab program, and that's back to the community, so final destination or interim destination, or they can remain in the hospital system. So interim destination, we're looking at, it's a temporary accommodation, a middle step to a final destination. So a patient might have completed their rehab program but might need some time in an interim destination for further rehab treatment, or they might need to wait for their final destination if they need, say, home modifications or for services to be in place, put in place. And here we've just got some examples. So Mrs. Jones was discharged to her local country hospital whilst awaiting approval for a care package to be set up in her own home. So she was discharged to the local country hospital, that's as a maintenance patient, so that is the interim accommodation, and then will be discharged back to her own home as a final accommodation. The second example we have here is Mr. Major, who was discharged to his daughter's home whilst awaiting completion of home modifications to his own home. So that's discharged to the daughter's home as the interim accommodation, and then his own home as the final accommodation. So we might not know how long either of these, Mrs. Jones or Mr. Major, are going to be spending at the hospital or the daughter's home, but the intention is there for the patients to return back to their own home, and therefore it should be coded as that. So final destination, we're looking at what is the most appropriate long-term accommodation for the patient, whether that's residential aged care, their own home, their daughter's home. All right, these are the codes for discharge destination for interim accommodation and final destination. So the first we've got here is private residence. We're looking at a patient's own home or a family member's home, or say a unit in a retirement village. In the example with Mr. Major, we've got that he's discharged to his daughter's home. So that's discharged to interim accommodation of private residence whilst awaiting completion of home mods to his own home. So again, that's discharged final accommodation of private residence. Then we've got residential aged care, so we're talking about nursing home placements. The next code is group home, so here we're looking at a shared accommodation. It might be a disability-specific supported accommodation service, and they may have access to personal care, living carers, skilled support staff as well. The next option is boarding house. So this is where a patient might be provided with a room. It's a hostel type accommodation. They don't have access to services, and generally it's probably used for the homeless population. So the next code is transitional living unit. This was originally set up to capture the specialist brain injury and spinal cord injury units. The characteristics of a transitional living unit is that it's short-term accommodation, there's therapeutic intervention, it's time-limited and goal-oriented. It's allowing time for the patient to focus on further developing functional capacity, and also developing independent living skills, with the idea that the patient is transitions back to their own home, or it can be used as a transition to a residential aged care facility. Just before we move on, we'll just briefly talk about the residential transition care program and the community transition care program. So this transition care service is a service for older people following hospital stay. There's the residential option would come under transitional living unit, as it's a transition service being received in a live-in facility. The community transition care program, it doesn't come under a transitional living unit. Rather, you code it as if the person's receiving it in their home, as discharged to private residence, and then you would select that they're receiving services on top of that. So then we've got the code hospital is just included in the interim destination code set. So that's if a patient is transferred to a hospital as an interim destination while they're awaiting placement, say home modifications to be set up, support services to be arranged, things like that. So that example there, Mrs. Jones is discharged to a local country hospital, so you would select that code as a maintenance patient whilst awaiting for her final accommodation to be set up. We have got the codes other and unknown there. We would just caution you around using those, as it doesn't provide information. If you do select other, if you can put in a comment saying what the destination was, and if you're finding that you're using it a lot or you're unsure how to code a certain thing, please contact us and we can talk to you about that further. So we'll just stop for questions, and we have got a couple here. So we have Ashley, your question there is, sorry, is that coded as final destination to home? What were you referring to?
Lovely. I was just meaning in terms of going to the interim and then on to the final destination. So if you're going to be going to an interim destination as into the daughter's property, do you mark it as interim or do you mark it as final?
It's interim. If they're going there as an interim destination, you mark it as interim, as private residence.
Okay, thank you.
So if the patient goes to the daughter's home because they're waiting for, say, modifications to be done to their own home, or services set up, we put discharge to interim accommodation, and the code is private residence, and then you would put the final destination, the code would again be private residence, because in both situations it's a private residence that they're going to. Does that make sense?
Next question.
All right, so the next question we've got here, would a transfer to rehab in the home program be known as interim destination as well? No, that would come under as a service, and it would be considered a separate episode of rehabilitation.
It's not discharged.
Okay, the next question is, what has been decided as the appropriate selection when discharge to the street? So is other or unknown for the homeless population. So if the street is a usual accommodation, then it will be discharged to private residence. If you could make a comment about where they're going in the general comments section, it would be interesting to see how often this would be being used.
Yeah, sorry, it's Frances here. I'm just going to comment briefly. This comes up from time to time, especially in places like, from places like St Vincent's in Sydney or some of the other major metro hospitals, where they do get people coming in whose normal residence is either a houseboat or under the local bridge or on the park bench, and they are the usual accommodation for those patients. And I know you guys out in the service land are often trying to find other places for people to live, but sometimes it's their choice and that's where they want to live. So we have had some discussions about whether next time we amend the code set, we actually put a code in there that reflects the homeless person, so that we can actually get some good data about that. But at this point, don't do it as other or unknown. Basically, it is their private residence. I know that sounds weird, but that's what it is.
Okay. Next question. Is there any time frame involved for interim destination? The answer is no. So as with an interim destination, what's important is that the intention is for the patient to go on to their final destination. It doesn't matter about time frames there. So with those examples, with Mrs. Jones going to the hospital, you might not know how long she was going to stay in that hospital, but you do know that the intention is there for her to go to back to her own home. Right, the next question, could you please clarify transitional living unit interim destination? We were advised last year that here in Western Australia there isn't any transitional living unit, and that if we have patients go to TCP to put interim destination as REH. So we are currently in the process of doing a review of the discharge destination codes, in particular around the transitional living units. We're finding that that services and states are using this a bit differently, so we're just trying to get some clarification around that and around the options and terminology that are being used, particularly around transition living units and transition care programs. If the person is receiving the transition care program and it's in a live-in residential facility, then it does come under a transitional living unit. If they're receiving it in their own home, then you would select that the patient has been discharged to the private residence and select that they're receiving services in their home. So the difference there is that if the person is receiving it at a living facility or their own home. Does that clarify that question? So the next question, does that mean we need a discharge FIM from rehab to rehab in the home? Yes, if a person is being discharged from your rehab program, for it to be considered complete, you need to enter the discharge FIM score. And then the rehab in the home program will be a separate episode. What do you put for discharge against medical advice? So that's back here at mode of episode end. If you come down to number 8, it's discharge at own risk. All right, the next question. What is your definition of multi-trauma 14.9? What do you define by any other system?
That's probably anything else that's not mentioned.
Yeah.
So, sorry, 14.9. So 14.1, 2 and 3 talk about brain and spine and other major orthopaedic. 14.9 is where it's clearly a multiple trauma but doesn't fit into 14.1, 2 and 3. That's about as much as we can say. If you've got a specific person in mind that you want to run past us, then I would suggest you just email into the AROC at uow.edu.au inbox and we'll do our best to try and help you work that one through.
Okay, so we might move on to the next topic. All right, so the next topic we're looking at comorbidities. So a comorbidity here is defined as any other significant existing illness or impairment, not part of the principal presenting condition, which has interfered with the process of rehabilitation. So it's important to identify if there are any comorbidities, as it may reflect a relationship between the presence of the comorbidity and the rehabilitation outcome and the length of stay. So these are the comorbidity data items. First, is there an existing comorbidity interfering with this episode? If you select yes, if you're entering onto our online system, it'll come up with the code set and you can select up to 4. So the general rules around comorbidities, we only record it if it has interfered with the rehabilitation program. And we should be able to clearly see this in the patient's medical record. You should be able to pick it up and see how it has impacted the patient's rehab program. If you do record a comorbidity and it has interfered with the program, it's highly likely that a suspension of their treatment has occurred, and we will be talking about that a bit later in the webinar. And here there is a code other, so again, just carefully consider using that as it doesn't provide information. If you do select it, if you can put a comment in about what the comorbidity is, and if you're finding that you're using the code other a lot for a patient group, then contact us and we can talk to you about that. So we've got some examples of comorbidities. So the first example here is a patient required extensive medication management for diabetes. They had variability in their blood sugar levels during the admission that affected their ability to participate in their rehab program. The next example we're looking at is a patient requiring a longer length of stay to accommodate fatigue after dialysis. And then we've got an example here of a patient who had one or more epileptic seizures that caused the patient to need extra time to recover and be able to participate in the same level prior to the fit. The last example we have is the patient developed a pressure ulcer during the acute admission and is then admitted to rehab. However, due to the pressure ulcer, was not able to engage at the anticipated intensity of the rehab program. So just important to note, despite the fact that the pressure ulcer occurred during the one hospital admission, it occurred prior to their rehab program, so it does come in as a comorbidity. And when you're listing comorbidities, it does provide a bit more information about the complexity of this patient's rehab admission. So we'll just stop for questions. Did anyone have any questions or anything they wanted to go over around comorbidities? I'll just unmute anyone. All right, oh, we've got one, hang on, I know a couple. Please also comment on the impact of psychiatric comorbidities. There is a code for here, number 6. Problems, yeah. There is a code for mental health problems. Perhaps if you do select this, you can add a comment a bit more specifically about what was occurring for that patient. And then obviously you'd be documenting in the patient's medical record about how it has impacted their rehabilitation. Time out for dialysis included. Yes, we've got the 2 codes here. Oh, sorry, you can't see my pointer. That's number 7 and number 8. Oh my God.
So with renal dialysis, we understand what you find, especially if it's a patient has to go off-site for renal dialysis. It takes quite an amount of time. There are services that manage the dialysis in such a way that the patient has their therapy in the morning and then goes off for dialysis in the afternoon. And in that case, it hasn't interfered with their therapy on that day. However, often when the patient comes back from dialysis, there are fatigue issues and they may not be able to participate in therapy the next day if they're very fatigued. So then it would have interfered with the rehab episode. Does that answer that question? Have you got another question?
I think you probably covered that question, but so can we please... Ooh. Sorry. Can we please clarify if the comorbidity impacts on their ability to participate in their rehab program, however, may not interrupt their whole rehab program episode?
There's a bit of you need to have a little bit of a clinical expertise here. So if you've got a patient you're coming in and you're designing a program knowing that they have some limitations, then that is the program. And it's only if something happens over and above that impacts the program that you've designed for them that you code it as a comorbidity. So I use pain as the example here. A lot of patients have pain. We don't code it as a comorbidity unless it's chronic pain. because there will be a degree of pain, and it's to be expected when they're coming from an acute episode into rehab that they will have some level of pain. You design the program around that to cope with that. It's not a particular comorbidity. I hope that sort of answers the question. Why is hearing impairment? I'm looking for it.
My pointer's not working.
Oh, 15. No, I can't. I can't actually give you an example of that one at this point in time. It was something that the clinical team, when they designed the comorbidities, they came up with. Perhaps it is someone whose hearing aid goes offline or something, so it becomes harder to communicate with them. I'm sorry, I can't actually answer that in any great detail for you, but it's a very good question. Yes, well, it could be because you need an interpreter and you can't get one. That is often an issue, that waiting for an interpreter can slow down a program. That's very true. Is there one at the bottom? This one. Delirium is in there as a comorbidity, number 5.
Just listed as pre-existing. They're just making a comment saying that the delirium.
Oh, it's not pre-existing.
So that will come under complication.
My question would be, it's not a comorbidity in that case. It's a complication, and my question would be, what's causing that delirium, and why is it being managed? Probably should be from a medical perspective.
So that would answer the true. Okay. All right. So we might move on to complications then. So complications. So a complication, we're looking at a disease or disorder that arises during the rehabilitation episode, concurrent with the principal impairment, which prevents the patient from engaging at the anticipated and intensity of their planned rehab program. These are the relevant data items. So again, it comes up, were there any complications interfering with this episode? If we select yes, then it comes up with this code set here. And again, we can only choose 4. So the general rules around using a complication is that we only want you to record it if it prevents the patient from engaging at the anticipated intensity of their rehab program. And we only record it if it arises during their rehab episode. If it occurs prior to the rehab episode, for example, the pressure ulcer, it will come under as a comorbidity. If they develop the pressure ulcer during their stay in the rehab program, then it will come in as a complication. And again, it should be evident what has happened and how it has impacted the patient's rehab program in their medical record. We'll cover what to do if a suspension occurs, and that there is a code set other. If you use it, provide any comment in the general comments about what the complication was, or contact us if you're not sure how to code something. So we've got some examples here of complications. So we have a spinal patient on bed rest who developed a pressure ulcer, which prevented him from engaging at the anticipated intensity. The next example here is a patient develops a UTI. During their stay, they become confused and are unable to engage at the anticipated intensity of their rehab program. And then the last example here is a patient had a fall, injured themselves, and was unable to engage at the anticipated intensity of the planned rehab program. So here again, you'll have to make a clinical judgment around what was their planned sort of intensity of their rehab program. Here we have just a little flow chart to go through. It's pretty straightforward. It's not so easy in practice, so a patient has a comorbidity or a complication arises during their episode. We look at, does this comorbidity or complication impact the patient's ability to participate in their rehab program? Then we select, so if we select no, it doesn't impact, then we do not record it as a comorbidity or complication. If we select that it does impact the patient's ability to participate in rehab, then we do record it as a comorbidity or complication. And then if we just go down to the bottom here, if the patient is unable to participate in their rehab program due to the comorbidity or complication, we'll need to record it as a suspension of their treatment. So we'll just pause for questions and then we'll move on to suspensions of rehab treatment. Did anyone have any questions or issues they wanted to talk about here? When does it need a suspension? So we'll cover that in the next topic, which I might move on to because there's no other questions. So for a suspension of rehab treatment, we're looking at an interruption occurring in the patient's rehabilitation program. So any requirement to suspend a rehabilitation program may significantly impact upon treatment outcomes and the efficiency with which these can be achieved. And yeah, so looking at outcomes there, length of stay and FIM change as well. So the relevant data items here are the total number of treatment suspension days and the number of treatment suspension occurrences. So a patient might have one suspension occurrence, which might last 1 day or 2 days or 3 days, or they might have like 3 treatment suspension occurrences, each occurrence lasting 1 day or 2 days. It's important that you collect that information correctly. So the rules around suspension are, if a patient's treatment is suspended and on return to the program, they're returning to the same rehabilitation program, a new program is not required, then this is counted as a suspension. It doesn't matter how long the patient's suspension was, as long as they're returning to the same rehabilitation program. We're not changing anything about the rehabilitation program. Yeah, so when they get back to the ward, they can just pick up straight from where they left off when they were transferred back to, say, acute. So if when the patient returns to the program or the ward, we need to develop a new rehabilitation program, their primary impairment might have changed or their functional status might have changed. All right, so if a patient participates in their program in the morning and then has to go out for a medical appointment or intervention, say renal dialysis in the afternoon, this is not considered a suspension of treatment because the patient has participated in that program on that day. If they leave the program for a day and do not participate in their program, then that would come in as a suspension of treatment. Just something to note here, if a patient refuses to participate in their rehab program, this isn't considered a suspension of treatment. So we've got some examples here of possible reasons for suspension. So the patient might have a medical condition, so the patient might have a flare-up of asthma, they develop breathing problems and therefore can't participate in their rehab program for a period of time. The patient might be on the rehab ward or they might have been transferred to an acute ward. So the location of the patient isn't relevant. It's whether or not they participated in their rehab program. The next example here is the patient might have had a requirement for a medical procedure, for example, renal dialysis or a gastroscopy, and the patient may need to be transferred to another facility for this procedure. Or the patient might have needed to attend a medical appointment.
So the other thing is when it's not a suspension. So for example, if you've had a patient on the ward, like the one that Alyce used before, who had a fall, but it was quite a serious fall, they had to go back to acute and then there was some, because of that fall, when they came back to the program of rehab, you had to change they're programmed to incorporate an orthopaedic component as well as the sort of stroke functional cognitive component that you had previously, that's a time when you would finish the first episode at the point that they had the fall and you transferred them. So they would have had one incomplete episode of rehabilitation, then they had a fall, they went back to acute for a period of time, they end up back in rehab, but it's a separate episode of rehabilitation. And in that particular instance, you'd probably say it was a change in impairment as well. So, I hope that makes sense.
So just with this flow chart, if a suspension occurs, it's just to, I guess, provide a bit more information on how to make a decision about whether a situation comes in as a suspension or not. So an interruption in the patient's treatment occurs when the patient comes back to the ward or back onto the under rehab care. We're looking at what level of function and impairment does the patient return with. So if they return with the same function and the same impairment, then it comes in as a suspension. It's considered a suspension. So we would use a suspension and record the number of days for one occurrence. If the patient returns with a different function but the same impairment, this is not considered a suspension. So you need to close the rehab episode, start a new episode, and answer no to the first admission for this impairment in the new episode. If a patient returns with a different function and different impairment, this again is not considered a suspension. So you close the rehab episode, start a new episode, and record the new impairment as the primary reason for this rehab episode. And then we've got just a little flow chart around how to code if a patient is discharged or transferred for 1 day and returns on the same day. So on return, did the patient participate in their rehab program for that day? If you select no, then we record it as a suspension. And if you select yes, they did participate, we do not record it as a suspension as they've engaged in their rehab program for that day. So that brings us to the end of suspensions of treatment, and we've just got a couple of questions coming through. Sorry. All right. Will this, where is this documented?
Where's what?
Where is what documented?
Suspensions?
We do have a resource on our website, which I can show you in a minute, that looks at suspensions in treatment and how to code that, and provides a bit more information about that. You can also find it in the data dictionary for clinicians as well.
Those little flowcharts we're going to create into a resource.
And we have those flowcharts that I've put in the presentation today. We will make accessible for you as a resource as well on our website. How can we tell if this is going to happen if the transfer back to acute is for months? So
it's highly likely if they've been away that long, their function will change.
For months?
It's highly likely if they've been away that long from rehab that their function will change.
Oh yeah, okay. So if a patient has been away from their rehab program for months, then it is highly likely that their function will have changed. A lot can happen in a month or months. So probably if someone is leaving your rehab program and you aren't certain about whether or not they're going to come back, it's probably wise to record a discharge FIM. And you should be able to do that because of the excellent documentation around the FIM items. Then we look, what's the next question? Does day leave count as a suspension? The answer is no. There is an item looking at leave days. Leave has to be over midnight, and it's generally towards the end of a rehab program where a patient might be going back home with, say, a carer to have a practice or a test drive before they get discharged. Or, yeah, they're just going out. Okay. Yes, so that doesn't count as a suspension. Fatigue with strokes often impacts rehab program, but I don't record as suspension, as it is usually just mentioned in case conference. Should I change this? No, you should not.
No. Fatigue is very much a recognised complication of stroke. And so when you plan a rehab program for a person with stroke, you're going to assume there'll be a degree of fatigue. So what you're doing is absolutely right. Just leave it as how you're doing it now.
You mentioned medical treatment / procedure. What about going to another facility for an MRI?
Yes, that happens if you're at a rehab facility that doesn't have access to an MRI and the patient has to go back for an MRI. If you've got it organised so they do their therapy in the morning, have their MRI in the afternoon, then it's not a suspension. If you can't do that and they have to go off for their MRI and miss their rehab program for that day, then it is a suspension.
Just out of interest, possibly an offline discussion, how do other facilities record all these suspensions, such as scans, procedures, etc., when it comes to recording suspensions accurately?
That's all to do with documentation, and when we do our benchmarking workshops, we often show what we see as quite an exemplar of a documentation of a patient's rehab episode. And as part of that documentation, there is a place where at case conference, when people say, oh, you know, Mrs. Jones had to go for her MRI, had to go for this or had to go for that, that it is noted in the record that it was a suspension or not a suspension. And then at the end of the patient's stay, all of those are added up and the data is inputted as appropriate. We can't show you that document right here and now, but I think it's actually under the tab that's called version 4 resources on the AROC website if you find that. Otherwise, just email in and we can show you.
So if a suspension is for a number of days, is length of stay affected? Yes.
No. No, suspensions are not deducted from the length of stay.
I didn't understand.
Leave days are deducted from the length of stay. So leave days, as Alyce said earlier, are generally mostly used in spinal cord brain injury and happen towards the end of an episode where the patient is actually going home to see if they can cope with the services and or carers that's put in place. Suspensions are not deducted from length of stay, but that's why it's important to collect them appropriately, because if you do have a cohort of patients that has a lot of suspensions, and then you will show your length of stay might be a bit longer, but you know why, and you can defend why they are longer because of this lots of little suspensions.
All right, so the next question, for instance, transfer to acute for months may lead to discharge from acute straight to home.
Correct.
So you would capture that in mode of episode end as transferred back to acute. So that doesn't come under as a suspension.
And it would be an incomplete episode because they didn't finish their rehab, I'm presuming. They didn't finish their rehab, they were transferred back to acute. Something happened there, they stayed there, and then they either went straight home or straight to wherever their next destination is without coming back to rehab. So all you can do then is code what happened to the end of rehab.
Okay, when mode of episode start is used as recommended rehab, does this automatically join the episodes and add on to the first one?
So you're talking about concatenation. So this is a process that we do where some jurisdictions' business rules require you to discharge and readmit, and we know that they are actually part of one episode, then yes, there are a series of business rules that allow us to glue all those little episodes together. So again, it happens more often in brain injury and spinal cord injury, where in spinal cord injury, patients are often popping back to acute for various procedures, and if the business rules of the jurisdiction require those in their own system to be little episodes, what we do is then glue them back together and show it in our data back to you as one big episode. I hope that makes sense. I'm happy to take that offline and talk about it if you want more information.
Okay, so Ballina rehab. We use synaptics and have no capacity to record suspension. We either end the episode and recommence, which involves end film and start film, or we record as reason for delay to discharge. Which way is best?
Yes, New South Wales publics are a bit of a problem because of the way Synaptics is set up. We actually acquired a copy of the Synaptics forms that you fill in. We're having a look at those in some detail, and hopefully we'll have be able to give some information or some suggested ways of working around those state-based business requirements, probably at the workshop, the benchmarking workshop that I'm running on the something of May, 22nd of May or 20th of May in New South Wales. Sorry, you're a bit of a special case, New South Wales.
So leave to home in the middle of rehab stay on a Wednesday, Thursday, Friday, impacting program, traumatic brain injury, leave for longer compliance. Not sure what.
If it's leave, you code it as leave. I would find it unusual that it's in the middle of a rehab stay, but there may be circumstances that make that a requirement for this particular patient. But leave has to occur over a midnight. So if they were away from the hospital for Wednesday midnight and Thursday midnight, then it is coded as 2 midnights and away, 2 leave days.
If the patient is doing physio and hydro and only does one, is this a suspension or not?
No.
Okay, I'm late to join the webinar. Will suspension day count as rehab length of stay or not?
Yes, it counts. We don't deduct the suspension days from the length of stay.
And we will be putting up a recording so you can go back and listen to the whole webinar once it's up on our website. So outpatient appointments, when they go to elsewhere for the day and miss rehab session, then it is a suspension.
Yes. Why are they in rehab and have outpatient? Yes. Okay. Yes. Yes. We'll leave it at yes. I'll leave my whys for later.
You mentioned that fatigue is a recognised complication of some conditions, so therefore it should be recorded as a complication if it interferes with the rehab program. If this is the case, there is no coding for fatigue. Should it be coded under other and clarified?
I did mention that fatigue is a recognised complication of some conditions, and therefore the program should be designed around expecting that there will be some issues with fatigue. So it's not actually a complication that arises out of the blue whilst they're in rehab. It is something that comes with the impairment of stroke in this instance. So no, there is no fatigue under complications.
Do I put as other and add comment that fatigue was impacting program, but that is only really underlying case conference?
No.
Yeah. Okay, that's all the questions. So before I hope that's clarified it.
Oh,
that's all right. We are putting it up on the website. I'll show you where it is just before we go.
Okay, good.
Awesome. Okay, so you can see that we've got a webinar schedule. We have got the 2 recordings up here of the first 2 that we've run, and then we've got 2 coming up in March that I mentioned earlier. And then if we go over...
So the recording for today will be accessed through there?
Yeah, the recording will be accessed here when it's up online. And then if I just go back to the main page, you can see here we've got a link for a feedback survey on the webinar. So it would be really amazing if you could take a minute to fill it out, just add in any comments. And then just quickly, I'll show you the tools and resources section. Tools and resources. Then we go version 4 resources here. And we've got the rehab care plan. And then just down the bottom here is that suspension of rehab treatment document. And we, as I said before, we'll be making the little flow charts accessible for you
as tools. Yeah.
As tools. And then just back to the presentation. Does anyone have any final questions before we end? And I've just got up here our contact details if you don't know. We've got our email there. It's probably the best way to contact us. We're all here and happy to help. Thank you.